Hello, this is Tom Leggett. I am the Director of Business Development here at SonoraQuest Laboratories. Joining me today we have Dr. Brian Koeneman. He is the Scientific Medical Director for Molecular Diagnostics at SonoraQuest Laboratories, and Brian Mochon, Scientific Medical Director for Infectious Disease Testing here at SonoraQuest Laboratories. We are bringing you this webinar today to discuss the different types of testing that are available for COVID-19 diagnosis. There are multiple tests that are out there. There also seems to be a lot of confusion in the marketplace right now in terms of how to use these tests, the different sensitivities and specificities and accuracies of these tests, and how they all relate to the limitations and strengths of each one of these. The first question that I should ask here is, what are the different platforms? What are the different tests that are available in the marketplace for COVID-19 testing? Dr. Mochon, could you answer that, please?
The best way to look at this is there's a diagnostic test, and those are broken into two different groups. So we have the rapid antigen tests, and these are detecting pieces of the virus or virus particles. Your other one is a molecular test, and you're actually looking for the presence of the viral RNA. So those two tests can be used to diagnose once someone becomes symptomatic. And then your other test that is COVID related are your antibody tests. And antibody tests are primarily used for people that have been exposed, never got tested with one of the two diagnostic tests that I just previously mentioned. And then they also can be used from a epidemiological perspective, where we can look for the prevalence of the virus in the community. So that's probably the best way to look at the two. So one is to see past exposures, and one is to look at diagnosing those that have the acute illness.
Dr. Koeneman, what are the indications for antigen-based testing for COVID-19?
So for antigen-based testing, we still want to have symptomatic patients, and this is something that it could take 7 to 10 days for some of the patients to have a high enough viral load to be detected by an antigen-based test.
Okay, so basically, to parrot back what you're saying, antigen-based testing is appropriate in those patients who are symptomatic. Is there any kind of window that's associated with that in terms of their symptomology and when it's appropriate? I mean, is there a point on the tail end of the infection where it may not be appropriate again to do antigen-based testing?
So yeah, for an antigen-based test, we have a window of, you want to wait probably about 5 to 7 days until you want to use that assay. It can take that many days to get to a high enough viral load that the concentration would be detected by the rapid antigen tests. Before that, though, that patient could still be asymptomatic and still be contagious and being able to spread. So we want to be able to catch people before they become in contact with other people around them, so that we can catch these population as quickly as possible. The rapid antigen tests sensitivity of being able to detect the low limits of viral concentration is limited, so you have to wait for that 5 to 7 days for that concentration to reach a threshold that can be detected by the rapid antigen tests.
Okay, great, thank you. And so, Dr. Koeneman, you've mentioned that there is a specific patient type that is appropriate for antigen-based testing. Now, what we hear out in the field is that the sensitivities and specificities related to both antigen testing as well as a molecular diagnostics test, like a PCR test, appear to be equivocal, right? They're all very high 90 percentile sensitivities and specificities. What's going on there? Because we know that generally speaking, the molecular diagnostics test, which takes longer to get a result on, seems to be a more accurate test.
Yeah, that's correct. So what we want to do is we have the most accurate test out there is still the molecular-based testing. And when you look at some of the package inserts for the antigen tests, you have to pay very close attention to the patient population that was being used in their study. And when you're looking at an antigen test that may appear to have a very high sensitivity You have to look at the patient population in terms of who did they test, and when did they test them. So when someone is infected, they typically have a peak viral load, 4 to 7 days after infection, and that is the patient population that they are specifically looking for. And so you've kind of got that population with a high viral load being tested with the antigen tests. For the PCR test or the molecular-based testing, you have a lot more sensitivity to it. We can detect lower amounts of the viral RNA, but it is also then looking at some of the patients that may have been pre that 5 days peak, and so you can detect people much earlier in the infection.
Great, great. And so I think that the term limit of detection is used to define that. Do you know what the limit of detection would be for perhaps the PCR testing that we're doing here at Sonora Quest versus some of the antigen-based platforms that are out there in the field right now? And perhaps it would be best to start by what does that term mean, limit of detection?
So for a limited detection, you're referring to the lowest level of viral concentration that you can detect by that specific test. So for example, for a limited detection for a rapid antigen test, you're looking for the protein itself and how much protein needs to be present before that test would be detected. For a molecular-based test, you're looking at how much RNA would have to be present for that test to detect the concentration of RNA. And the molecular-based tests have a much lower limit of detection, so it means it needs fewer virus genetic material there to be able to pull that result, as opposed to a rapid antigen test. And so when you're looking at that sensitivity or that limit of detection specifically, you can be tens of thousands of times more sensitive on a molecular-based test than on a rapid antigen test.
When it comes down to discussing the copies per milliliter, if you're comfortable discussing that for the testing that we do here at Sonora Quest versus copies per milliliter for something like the Abbott Sophia 2 or the Binax Now antigen test, do you have any kind of a feel for what that number would be for the two different types of testing?
Yeah, that's a great point to be able to look at the limit of detection and pay close attention to what is on their package insert, because they all have very different nomenclature. So you have to be able to compare one directly to another. It can be hard at times. And so what we want to do is to be able to try to compare this as best as we can. But for a molecular-based test, here at Sonora Quest, we have some very highly sensitive tests that have limits of detection below 100 copies per milliliter of solution. So it's a very low concentration to be able to pull that up. They have for the rapid antigen tests, as we discussed a little bit earlier, those can be thousands of times more of a concentration to be able to pull that detection rate from there.
So with that being said, 20,000 times less sensitive, so to speak, in terms of a limit of detection, that puts their copies per milliliter somewhere in the range of 10 to the 6th copies per milliliter, hundreds of thousands of copies per milliliter versus under 100 copies per milliliter for molecular diagnostics. And I guess that's important. Obviously, we're trying to find these patients and diagnose these patients as early as possible so that we can stop the spread. But that would bring up the question, well, is it possible for a patient who isn't showing signs and symptoms, is it possible for that person to actually spread to spread COVID? Dr. Mochon, do you have any thoughts on that?
Some of the data that's come out so far is showing that around 40 to 45% of people that have COVID are asymptomatic. And data from some other studies have shown that individuals that are both that where they've measured the viral load in someone who's symptomatic versus someone who's asymptomatic have very similar viral loads, meaning that someone can be just as contagious without showing any physical symptoms, no coughing, no runny nose, and they're still able to spread the virus to others.
Do we have any ideas how long a person might, while that viral load ramps up, how long that person might actually be contagious before they start showing symptoms, if they're going to start showing symptoms? Is there any data around that?
I think there's two things that we need to probably break into categories, right? So someone who's showing no symptoms but has the virus can be either pre-symptomatic or asymptomatic. And so someone who's pre-symptomatic is someone who's defined as they've acquired the virus within their body. They've yet to make any physical symptoms, no coughing, no fever, no runny nose, but will later on develop symptoms. And so that's your pre-symptomatic group. And then you also have your asymptomatic group that will have been transmitted and exposed to the virus, but will never develop any true symptoms throughout the course of their infection. So I think it's important to kind of distinguish those two. We know that in both instances, those that are both pre-symptomatic and asymptomatic can have viral loads very similar to those that are symptomatic. And obviously those titers change over time, but probably the biggest issue is that the PCR test will allow one to more accurately detect those that are asymptomatic and detect those that are pre-symptomatic before they start showing symptoms. Whereas we know that the antigen test has been, the clinical performance of these tests have only been measured within that symptomatic period, usually from date of onset or to days 5 through 7, depending upon what antigen test you're looking at.
With that being said, what is the need, or is there even a need? I don't want to assume anything. Is there a need to reflex antigen-based testing to a molecular test under certain circumstances? Dr. Mochon, what do you say? There's
a need for rapid antigen tests, right? So it's a test that is readily available, that it can be performed very easily. It's a wave test in most cases, and so this would allow, you could use this at a sporting event, or you could use this as a means to get into whatever sort of exhibition. But there's going to be also obviously limitations to this, like we just talked about, right? So we know that this is going to be something that is not completely reliable. So we know that a lot of universities are using these rapid antigen tests on their athletes so that they can perform in games or matches or whatever. But there's been cases where these have been false negative and false positive, and so to me, it's correlating the clinical symptoms with the result of the test. So if the person is symptomatic and you've used an antigen test and it's positive, then most likely the result is accurate and correct. If they're symptomatic and you get a negative result, they could have influenza. They could have another respiratory virus that has similar symptomology. But knowing that the COVID is going to be more prevalent than influenza now, especially before the respiratory season typically starts, then it would make sense to reflex to a PCR test. And then the vice versa is true, right? If someone's asymptomatic and you test them and they're positive, we know that the positive predictive value for these particular tests, when used outside of the scope of what they were designed for, that may be a false positive result. So it makes sense to, again, use PCR to confirm whether that positive antigen test makes sense in that asymptomatic person.
Great, thank you. That makes sense. I think one final question that I have is, again, feedback from the field, is whether the molecular diagnostic testing is too sensitive. Is it overly sensitive? Because it does pick up very minute traces of virus. Dr. Koeneman, do you have any thoughts on that?
I think looking at the molecular test, it can't be too sensitive in terms of trying to detect someone prior to symptoms or early on in their infection. So this is a great test to be able to have, trying to detect people that could be at a low level but yet climbing. And we want to be able to get the results to these people so that they can get in their own self-quarantine and not spread the virus out there. And then, and so if you look at the life cycle of the viral infection, you have low levels, it peaks, and then it comes back down. Once it's coming back down, the person could still have quite a bit of RNA left within the body, and that'll be detected for weeks. And if not, there's cases of months after infection of people still being detected. But if someone is symptomatic after that point of roughly 10 to 14 days, it's believed that they're not really contagious at that point. And so that the PCR test isn't a test of cure to look for someone if they're cleared, but if you follow the signs and symptoms of that 10 to 14 days, that might be the ruler for now.
Okay, that makes a lot of sense. Thank you. Thank you so much for your time. We really appreciate it. I hope this has been helpful to everyone out there listening. Please, if you do have any follow-up questions, you can direct them to me. My email address is tom.leggett, Leggett, @sonoraquest.com. Thank you again for joining us, and have a great day.